Now we will move from specialist healthcare to the primary healthcare services. We know that implementation processes can be tedious there as well. And the second speaker today is doing interesting research on this topic. The next speaker is Gunn-Hilde Rotvold. Gunn-Hilde is a sociologist and has worked for many years in the e-health sector as both a project manager and also a top manager. Gunn-Hilde now works as a PhD fellow at our center, and her research brings important knowledge to how the primary healthcare services can succeed in implementing e-health solutions. We look forward to your presentation, Gunn-Hilde.
Thank you very much. And hello, everyone. It's a pleasure to present something that interests me a lot, and introducing health and welfare technology, or as you can see in the title, telecare, in Norwegian municipalities is something that has been going for some years. The concept of welfare technology is a subtopic under e-health umbrella, and we use different ways of talking about welfare technology in different countries, and telecare is a very English word for almost the same thing. But I will show you some example of what kind of technology I'm talking about later. Norway has 356 municipalities. They differ in size, in geography, and demographics. And the smallest municipality has only 192 inhabitants, while the biggest one has a population of almost 700,000. The most average number is under 5,000 inhabitants. So more than 50% of Norwegian municipalities has under 5,000 inhabitants. The municipalities are responsible for providing reasonable, high quality healthcare and social services to everyone in need, regardless of age or diagnosis. And nursing homes and home care are typically municipality tasks, and many other primary care tasks, of course. Norway, as in the rest of Europe, experienced increased pressure on the health and care service due to the growth of the elderly, and at the same time reduced access to healthcare personnel. And today most people wish to stay in their homes as long as possible. There has been a lot of national plans and white papers that gives direction to the municipalities. Over the last 10 years, I picked some of the most influential plans and white papers that municipality look to. And as you can see, the first one, innovation in care services, focused on how to change and how to innovate the care to meet these challenges. Then you have the future care, and then you have a plan called A Full Life, All Your Life. It's more like a person-centered view in that plan. And the last one I picked is what we call the National Health and Hospital Plan. This plan is also influencing what's going on in the municipality. So planned policy and individual demand leads to less institutional care and increased focus on home care in the future. And the key question, and which is my interest, is how can technology contribute to providing high quality health care and social services to everyone in need of them. Politically, there are high expectations on how health and welfare technology can contribute to the situation because of the expectation of increased safety, the mastering and the independence and the ability to stay longer at home. Technology could make an impact. So far, these kind of technologies that you see on the pictures are the most spread welfare technology in Norway. And what you see is a digital security alarm which you can have additional sensors connected. We also have spread a lot of electronic medication support. Location technology as GPS is also everything is relative, but it's in use in many municipalities. And we also have supervision technology. This is not in the picture, but supervision technology is also in use in many municipalities to monitor risk situations. Supervision technology is used both in nursing homes and in home care, and also recently at some hospital departments where they have elderly. The introduction of welfare technology is, as I say, high on the national political agenda in Norway. And many municipalities have several years of experience from projects where they have tested welfare technology to increase the quality of health services. Directorate of Health, Directorate of e-Health, and the Norwegian Association of Local and Regional Authorities, what we call KS in Norway, established the National Welfare Technology Program in 2013. They announced projects funds to encourage municipalities to develop pilot projects. And the first municipality started in 2014. And today, almost all municipalities in Norway have activities related to welfare technology. And what this national program is providing municipalities is they have provided them funding, they have developed national recommendations, they have developed quick guides, they offer process guidance, they have learning programs, and they have websites, they have Facebook groups and meeting places and seminars, so that there are a lot of possibilities for municipalities to learn from each other. But still, few have integrated welfare technology into their ordinary praxis at the moment. Municipalities document electronic medication support like GPS and surveillance technology in the patient records. And these registrations are visible on the municipal patient registers. And by the end of 2021, the numbers in total show that we had 5,449 electronic medication support in use in Norway. We had 3,162 GPS and 5,940 surveillance technology. But only 149 municipalities use one or more of these technologies. And as you can see in the column, the orange one is from last year, from 2020, and the green one is from 2021. Only 44 municipalities uses more than 20 electronic medication support in 2021. There is an increase. That's why I picked both columns, because it has increased and it's still increasing. And that's a very good sign. And 26 municipalities use 20 or more GPS, and 51 municipalities uses more than 20 when it comes to surveillance technology. So this picture tells us also that 207 municipalities have no registered activity, and still they have a high focus on welfare technology, and which bring me to my research questions. I'm looking specifically on how municipalities introduce welfare technology. What happens when municipal health service introduce welfare technology, and which factors come into play? How do the municipality organize their introduction of welfare technology, and What are the inhibiting and promoting factors in introducing welfare technology in the municipal health service? I'm currently conducting empirical studies in 5 Norwegian municipalities. And these municipalities are selected by geography. I wanted differences in where they are geographically placed in Norway. Also wanted difference in size and how they have approached health and welfare technology. So my research is a qualitative study based on a grounded theory approach. That means I would like to ask people working in the municipality what's happening, what's their experience. I have no theoretical model that I bring into this from the start. I will develop theoretical concepts after studying what people have told me. I've looked into relevant documents, participated in internal seminars, and been in dialogue with employees and I have done observations. I do field notes from all these meetings. I have also done 45 individual interviews and with welfare technology coordinators, managers, IT personnel, politicians, and representatives from the end users. I plan to do focus group, but that's something I haven't done yet. So the use of welfare technology among the 5 municipalities I study have a considerable variation in how many electronic medication support, GPS and surveillance technology, and what they have registered as use. The standard view is that all have a small scale compared to their potential. Despite the relatively low numbers from this table, the activity in all my municipalities is high. All work with one or several kinds of technologies, but they don't register it. Intelligent sensors are connected to the ordinary safety alarm. Municipalities also have increased the use of electronic door alarms and video connections. There are no routines for the registrations of these technologies. And looking only at the registrations, it could seems like there are no activity, but there is a lot. So what happens in the municipalities? The core of my material covers actors who are in the initiation phase of welfare technology. I have interviewed entrepreneurs who are rigging for planned change of practice. So far, I have identified 2 areas as characteristics. It's the coordination and the correlation between the standardization and exchange of experience. Currently, I'm analyzing the coordination. There are 2 functions that are very visible and familiar to all municipalities: the welfare technology coordinator position and response service. I see the welfare technology coordinators as a municipal response to integrating welfare technology as part of their standard service. The welfare technology coordinator is an expression of how the municipalities formalize the introduction. And response service results from increased complexity when many technologies with alarm functions are connected. Response service is not as planned as the welfare technology coordinator seemed to be. So this is something that I need to dig deeper into to see what is the different approaches to this response service. But response service is really important in order to get the efficiency out of working in new ways. The needs for routines, procedures, responsibility, etc. is high, and that's also something that the municipalities have a lot of attention on. There's a lot of activity going on with less technology in use. My working questions to analyze the situation now is to ask, where does the function of the coordinator occur and how is it justified? How is this feature designed, and are there standard features and differences between the municipalities, or are similar strategies used or different? What experiences do they express? How do the coordinators navigate their roles? And in Norway, with many municipalities that differ in size, geography, and demographics, there will be variations in how they organize welfare technology into routine practice. And my contribution will shed light on how they navigate between national guidelines and local practices. So thank you very much for listening.